Next speaker, Dr. Meena, IOL issues in posterior segment diseases. Actually, Hoffer Q, I read somewhere, it is a formula which Hoffer Q wants people to disregard. It has to be abolished. But people still have been using Hoffer Q. In fact, the recent publications also see that. So he came up with Hoffer QST formula. So that was adopted by the ESCRS website, and I think it is we should be using it as a free formula. If you go to the website, you get it free of cost. Transcription errors have to be avoided, but I think it is a very good formula too, and serves all kinds of purposes. It's a kind of a lens suite, IOL power suite. Over to you, Dr. Meena.
Good morning, friends. I'll be speaking on a special situation when patients with a posterior segment disorder undergoes cataract surgery, and I thank Arun for giving me this opportunity. There are certain clinical scenarios that we deal with. We would be performing phaco in a vitrectomized eye or a combined phaco-vitrectomy, or the phaco could be combined with the silicone oil removal, and there is again the post-buckled eye, which have to be dealt with. When you look at the IOL consideration in patients with posterior segment diseases, these are the few challenges that we face in the axial length determination. There may be variation in the depth of the anterior chamber depending upon the tapenade agent that has been used, and this would lead to a variation in the final IOL position. Certain adjustments have to be factored in the appropriate IOL power that we use in patients with posterior segment diseases. The most important cause of error in IOL power calculation is the error in the axial length measurement. It could either be an overestimation or underestimation of the axial length. The axial length could be overestimated in a silicone oil filled eye where the sound is dampened because of the higher refractive index of the silicone oil. It could be underestimated when you are using an ultrasound biometry in a patient with macular edema where phaco-vitrectomy is performed. And again, an underestimation of the axial length while using the optical biometer can occur in dealing with a patient with a very bullous rhegmatogenous retinal detachment. This is because the laser produces a good signal-to-noise ratio from the detached retina, and when there is so much separation between the retina and the retinal pigment epithelium, you get an underestimation of the axial length. In such a situation, it is best to perform the axial length measurement with the patient lying down when the shifting fluid shifts to the periphery of the vitreous cavity, and you get a good axial length measurement. The ideal situation would be to perform a pre-vitrectomy biometry in all patients who walk in for a vitrectomy, especially in eyes where there is a chance that a silicone oil tamponade has to be done. The IOL power the measurement of the axial length in a silicone oil-filled eye is best with an optical biometer, and as emphasized by all the previous speakers, in any situation if the optical biometry is available, that would be the best thing to opt for when measuring the axial length, because the optical laser does not interfere with the silicone oil and the multiple interfaces that an emulsified silicone oil could produce in the eye. However, when you have a challenging situation such as a very dense cataract, the optical biometry would not be useful because the patient will not be able to fixate at the laser target, and in such a situation, we still have to resort to using the ultrasound biometer. If you are using the optical biometer, select the option of vitreous cavity filled with silicone oil, and the refractive index of light would change from 1.33 in the normal vitreous to 1.4 in silicone oil filled eye, and you effortlessly get a reading. But if you are using an ultrasound biometer in a silicone oil filled eye, please bear in mind that the speed of sound in the medium is inversely related to the refractive index of the medium, and the silicone oil has a higher refractive index than the normal vitreous, and it reduces the speed of sound by approximately 36%. This would lead to an apparent lengthening of the globe and a longer axial length measurement, and we also have to bear in mind the fact that the patient may have emulsification of the silicone oil, which will produce reduplication echoes, and you have poor post-retinal echoes. The necessity to convert the apparent axial length to the true axial length, making adjustments for the speed of ultrasound in silicone oil filled eye, has also to be borne in mind. If you have an eye like this, sometimes we see patients with a hyperoleon and very densely emulsified silicone oil. Measurement of the axial length using either the optical biometer or the ultrasound biometer would be very difficult because of the multiple interfaces that are created. If you are using an ultrasound biometer in a silicon oil filled eye and you do not have the option in your machine to change the velocity gates, where all the gates are set at 1532, which is the velocity of sound in a normal media, then you would have about 10 millimeter difference in the axial length. In this situation, you have to have a corrected vitreous cavity depth by making use of a formula-based calculation, or you can use a conversion factor to convert the axial length that you measure in the silicon oil filled eye to the corrected axial length. But if you have the option of setting the velocity gates in your machine, then you can set in the velocity gates to 1040 meters per second if you're using 5,000 centistrokes of silicon oil, or if you're using 1,000, it can be set at 980 meters per second. However, when you have a patient coming in from somewhere, we are not aware of whether the silicon oil in the eye is 1,000, 1,300, or 5,000 centistrokes, there is still, again, the margin for error. We again have a situation when there is an incomplete silicon oil fill and presence of a retrosilicon oil space, which is filled with the posteriorly circulated aqueous. And this is maximum when the patient lies in the supine position and minimum in the prone position. In such a situation, you can either opt for performing the axial length measurement using the ultrasound biometer, the patient sitting up, or you can use a CT scan to measure the axial length. We have to bear in mind that the refractive index of the silicon oil is higher than that of the normal vitreous and almost closer to the refractive index of the intraocular lens that we put in the eye. And hence, the silicon oil will act as a minus lens in the eye and utilize the power of the lens that you implant. This will account for a refractive hyperopic shift in refraction, which is maximum if the lens is a biconvex lens and least if you are using a meniscus lens. The planoconvex lens would come somewhere in between. Therefore, if you have an eye in which the retina is unstable and you don't plan to remove the silicon oil, where an indefinite tamponade is planned, it would be wise to use the rule of the thumb and add about 3 to 8 diopters to be added to the IOL power that is calculated to achieve metropia. However, it is prudent to counsel the patient about the myopic shift that is expected if there is a necessity to remove the silicon oil at a later date. The additional IOL power can also be calculated by using this formula, factoring in the refractive index of silicon oil, vitreous, the axial length, that is the corrected axial length that we measure, and the anterior chamber depth. We move on to the next situation when a phaco-vitrectomy is performed for a macular pathology, where it would be ideal to measure the axial length using an optical biometer, but if you're using the ultrasound biometer, there is a margin of error and a postoperative myopic surprise when the macular thickness comes back to normal, because the ultrasound biometer measures only up to the internal limiting membrane, and you have a thickened macula underneath that, and there is an underestimation of the axial length measurement. Also, there is a modification of the anterior chamber depth, which could occur when there is a gas tamponade or silicon oil fill. And in such a situation, in a patient undergoing a combined surgery, there is a chance of a slight myopic shift in the postoperative refraction, which could be due to the axial length error, measurement error, a difference in the refractive index between the vitreous and the aqueous filling the posteriorly circulating aqueous filling the vitreous cavity, and a modification of the anterior chamber length, and you have to compensate for the underestimated. In the presence of an intraocular gas tamponade, there is a forward movement of the lens iris diaphragm, and the lens remains anteriorly positioned, fixated even after the gas has disappeared, which accounts for a myopic shift in the refraction. So you can expect a myopic surprise unless you correct for it. If you look at scleral buccal dyes, the encircling and segmental buckles produce a lot of biomechanical property changes in the eye, which could be a slow-growing process, which is supposed to stabilize by about 3 to 6 months after the buckling procedure, but in reality, it goes on for a year or so. The axial length lengthens by about 1 millimeter, and this accounts for too strong an IOL and a myopic error. And if you're taking up such an eye which has been buckled recently, it is prudent to wait for at least 3 to 6 months before taking up the buckle dye. And the more the axial length elongation is associated with a 360-degree buckle and extensive use of cryopexy. There are certain situations when the axial length is impossible to obtain. In such a situation, you can use a CT scan to measure the axial length, or you can go for an intraoperative biometry or an intraoperative retinoscopy, making use of the following formula to calculate the axial length. A lot has been talked about the accuracy of the new generation intraocular lens formulas. The newer formulas exhibited better prediction accuracy compared to traditional formulas. And these are the various situations that I talked about. The cane formula works best in almost all the situations, except when you do a phaco silicone oil removal, where the Barrett Universal 2 has been found to be better than the cane, and in post-buccal dyes, the Barrett Universal 2 is better. If you have an eye with an axial length of more than 26 millimeter, it would be ideal to opt for the Holiday 1 with the Bangkok axial length adjustments. So friends, we are dealing with an intrinsically challenged eye where a full recovery, visual recovery may not be possible because of the basic vitreoretinal pathology, and we should spare no effort to optimize the visual outcome in these patients and not add to the patient's woe by implanting a wrong power IOL. I thank you very much for your patient hearing.
Thanks a lot, Meena, for a comprehensive